So today we are going to talk about anatomy of the lower respiratory tract, right? And this is a very basic subject, so I'm not going to dive too deep into it. We'll just go through it very quickly. So, what are the functions of respiratory system? Gas exchange, right? Moving air to and from the exchange surface. So, gas exchange is between the blood and the air. It also helps to produce sound, detect the olfactory stimuli, and very important is protects the exchange surfaces from environmental variations and pathogens. Right. So previously it was thought that lungs were having sterile environment, but this is not true. So lungs also have resident flora in them, just like our gastrointestinal system. So previously we thought that only gastrointestinal system was having flora, but now we also know that lungs also have resident flora. Right? So we all know trachea is a membranocartilaginous ring, right? Trachea is a membranocartilaginous ring tube extending from C6 vertebra to T4 vertebra, and T4-5 corresponds to the angle of Lewis. We all know at T4-5 the trachea divides into two main bronchi, the right main bronchus and left main bronchus. It is a rigid fibroelastic structure lined by ciliated columnar epithelium and C-shaped cartilaginous rings maintain the patency of the trachea. What is the length of the trachea? If anybody asks, it is 11 centimeter long. How many cartilaginous rings? 18 to 22 cartilaginous rings. So 11 twos are 22, right? 11 centimeters long and 22 cartilaginous rings. Outer layer consists of fibrous and elastic tissue encloses the cartilages. The middle layer consists of bands of smooth muscles, right, in a helical manner, and some areolar tissue. Inner lining consists of ciliated columnar epithelium containing mucus secreting goblet cells. So we all know mucus secreting goblet cells are present right here. Sorry, right here. These are the ciliated cells, right? These are the mucus glands, right? In the areolar tissue. This is the areolar tissue. This is the cartilaginous tissue with the chondrocytes, which we can see. And here are the smooth muscle layer. Smooth muscle layer is here, right? This is surrounded by smooth muscle layer. Okay, and what we can see over here is mucociliary escalator. Can you see this? This is the mucociliary escalator. It is marked, and you can see the arrow going upwards. Right? Here is the mucus layer, and here are the particle of the debris. This is another There is another section, and this is a transverse section where the outer layer we can see. This is the outer layer. This is the perichondrium. Okay, inside is the cartilaginous ring, the hyaline cartilaginous ring, which you can see. Right, it is very clearly marked, hyaline cartilaginous ring. And here is the mucosa, the mucus glands, and over here, which we can see the small pikes. These are the small pikes. Okay, sorry. This structure. This is the pseudo-stratified ciliated columnar epithelium, right? And anteriorly is the, sorry, posteriorly is the trachealis muscle. The trachea divides, as I told you, into right main bronchus and left main bronchus. So over here it is shown very nicely, which further divides into intermediate bronchus and lobar bronchus, which further divides into upper, middle, lower lobar bronchus. Okay, and on the right side there are three divisions, right? This is the upper lobar bronchus, the middle lobar bronchus, and the lower lobar bronchus, right? And on the left side there are only two divisions, upper lobar bronchus and lower lobar bronchus. So this is the main trachea, the primary right bronchus, primary left bronchus. It divides into upper lobar bronchus. Over here is the upper lobar bronchus, this is the middle lobar bronchus, this is the lower lobar bronchus. Right main bronchi is further divided into bronchus intermedius, right? This is also called bronchus intermedius. On the left side, this is the superior or the upper lobar bronchus, and this is the inferior or the lower lobar bronchus, right? Now this is further divided into upper apical, anterior and posterior, apical, anterior, and posterior, apical, anterior, posterior. This is the basal, medial, and again here this is the same thing, apical, anterior, posterior, basal. These are the parts of the lower lobe. Again over here you can see intrapulmonary structures. These are intrapulmonary structures and these are extrapulmonary structures. So lingula, again I will tell you what the lingula is divided into. There is a superior division bronchus, there is a lingular bronchus and the lower lobe bronchus. So what are the anterior relations of the trachea? Anteriorly it is connected to the sternohyoid, sternothyroid, inferior thyroid veins, thyroid gland and the cervical fascia. Posterior relation of the trachea is with the esophagus, right? And in the thorax it is anterior to the trachea is the aortic arch, the manubrium sterni, the common carotid arteries, the remains of the thymus and the left innominate vein. So the trachealis muscle, this trachealis muscle, yeah, it is an elastic structure. So this is posteriorly placed. So this is posteriorly placed, right? Why posteriorly? Because the esophagus is connected to this trachealis muscle, and this when we swallow food, so this trachealis muscle can elongate and accommodate the downward going bolus of food. What are the lateral relations of the trachea? Over here we can see very nicely the common carotid arteries, the lateral lobes of the thyroid, the recurrent laryngeal nerve, superior laryngeal nerve and its divisions, and common carotid arteries. See, this we can see the trachea, the esophagus, and this is the trachealis muscle, right? So here is the thoracic duct, which is coming and joining in the brachycephalic veins. On the left side, the arch of azygos vein, the right main bronchus, the left main bronchus, the left bronchial artery, and the right bronchial artery. Right? It is going right at the carina. Right bronchial artery is right at the carina. Okay. So why is this very important? The bronchial arteries are important because they are the most common cause of hemoptysis. Right? Correct. So they are the most common cause of hemoptysis. And the blood supply of trachea. Trachea receives its blood supply from the inferior thyroid artery and the bronchial arteries. So it has a systemic blood supply. Okay. Over here we can see the tracheoesophageal artery going into the primary tracheal artery, going into primary esophageal artery, and secondary tracheal branch to the posterior wall, and these going into the submucosal capillary plexus, right? So the characteristic of bronchi, which is very commonly asked by all professors, in first year, almost all the professors had asked us this question: the difference between right bronchus and the left bronchus. The right bronchus is wider, it is shorter and more straight as compared to the left main bronchus, and it is at an angle of 25 degrees with the midline. Hence, it is more straight. It enters the right lung nearly opposite to the T5 vertebra and gives off the branch to the superior lobe of lung before entering the hilum, then divides into middle and inferior lobar bronchus once in the hilum. The left bronchus is longer and narrower. So this is wider, shorter and more straight. This is wider, shorter and more straight. This is longer and narrower as compared to the right one. An angle of 65 degrees with the midline, more horizontal than the right one, and enters the left lung nearly opposite to the T6 vertebra. It enters the hilum and then divides into superior and inferior bronchus. So this is the question that they used to ask, that what is the angle that the right bronchus makes with the midline. Okay, so we can say it is 25 degrees. We can say it is 25 degrees. Okay. Which is why right bronchus gets more often, it has foreign body obstruction, and many a times when we are doing intubation, the right bronchus or the right lung gets intubated and the left bronchus is, or the left lung is unventilated. This kind of things happen. So that is why we have to auscultate after every intubation. We have to immediately auscultate and see if there is reduced entry on the left side. We have to pull out the endotracheal tube. Okay, just don't keep it over there, otherwise there can be pneumothorax. It is very common. Pneumothorax is very common after intubation. So each lobar bronchus divides within the lobe into tertiary bronchi, which is also called as the segmental bronchi. The bronchioles are typically 1 millimeters in diameter and lack the fibrocartilaginous network and the secretory gland structures cells which are present in the bronchi, and therefore the terminal bronchioles can passively dilate during inspiration. So this is very important point, that bronchioles are 1 mm in diameter. They lack the fibrocartilaginous network and the secretory gland cells which are present in the bronchi. Therefore, terminal bronchioles can passively dilate during inspiration. This is your DNB question, DNB theory paper question. Difference between bronchiole and bronchi. What is the difference between a bronchiole and bronchi? This has been previously asked, and I don't remember the paper or the year it was asked in, but I specifically remember that this was a question which was asked. So each segmental bronchus enters into the bronchopulmonary segment. This is another difference which we can write, that segmental bronchus, right, it enters the bronchopulmonary segment, and bronchiole becomes the alveolar duct and the alveolar sac. So every bronchopulmonary segment is pyramidal. Bronchopulmonary segment is pyramidal in shape with its apex directed towards the hilum, right? This is important. This is very, very important. Why? I will tell you when we discuss the definition of the bronchopulmonary segment, right? So this is the definition of the bronchopulmonary segment. So bronchopulmonary segment has its own segmental bronchus, first of all, and the segmental bronchus, artery and lymphatic drainage, right? So what we have learned is bronchopulmonary segment is a pyramidal structure with its base towards the hilum. Its base is towards the hilum. Sorry, apex is towards the hilum. And bronchopulmonary segment has its own segmental bronchus, and artery and lymphatic drainage. So over here we can see this is the bronchopulmonary segment. It has its own artery, right, and it has its own lymphatic supply, and these are the intersegmental veins, not intrasegmental. These are intersegmental veins. So bronchopulmonary segments are drained by the intersegmental veins. Okay. Why it is important? Why the bronchopulmonary segment is asked in the DNB papers? Because it is the smallest and functionally independent area of lung which can be removed without affecting the adjacent regions. Okay. It is the smallest and functionally independent. It is the smallest and functionally independent area of lung which can be removed without affecting the adjacent regions. That is why we do segmentectomy in lung collapse or in abscess, lung abscess. We do segmentectomy. Okay, it is preferred over pneumonectomy or hemipneumonectomy. Always segmentectomy is preferred, right? Why? Because it is the smallest and functionally independent area of lung which can be removed without affecting the adjacent regions. So bronchi blood supply on the right side is by a single bronchial artery arising from the right third posterior intercostal artery, and blood supply on the left side is by left posterior intercostal artery, bronchial artery, both arising from the descending aorta. Okay, coming to the alveoli. It is a thin-walled polyhedral sac. Its number increases with age and is maximum at 9 to 10 years of age. It is thin-walled polyhedral sac and maximum number is at 9 to 10 years of age. The largest alveoli are at the apex in the upright position. The largest alveoli are at the apex. Okay, these are all questions, right? These are all professor questions. What a professor can ask or should ask, these are those kind of questions. So the gas exchange is facilitated by the pulmonary capillary bed, which is the densest capillary network in the body. The alveolar in the body, okay, it is the densest one in the body. The alveolar wall consists of a thin capillary epithelial cell, then the basement membrane, then the pulmonary capillary endothelial cell, and a surfactant lining layer. So type 1 cells cover 80% of the alveolar surface and have thin cytoplasmic projections that help with gas exchange. These type 1 cells are highly differentiated but metabolically limited, hence highly susceptible to injury. The type 2 cells produce surfactant, which we all know, and have high metabolic and enzymatic activity. And type 1 and 2 cells have tight intracellular junctions and are almost impermeable to fluid. Type 3 cells are alveolar macrophages and provide immunologic lung defense. Okay. So over here we can see the type 2 cell and type 1 cell. Now the question is, which cells I can write over here also, which type of cells which type of cells are more in number. Okay. This is a first year question. I know many of you would be already knowing it, right? But this is a first year question, and many a times I myself have had made a mistake, correct? So very easy question, but many a times professor asks these kind of questions to check if you have read thoroughly or not. So I want you to answer this in the comments. Let's see how many of you can answer it. The alveoli is supplied by the pulmonary venules and is drained by the pulmonary capillaries. Right. So in this image, we can see the venule, the pulmonary arteriole carrying the deoxygenated blood, and the pulmonary venule carrying the oxygenated blood. Okay. And these are the bronchioles, the pores of Kohn. Okay, the alveolar duct, alveolar sac or the alveoli. So this is very important. The pores of Kohn, they are the communicating structure between two alveoli. They are the communicating structures between two alveoli. Sorry, I just cannot make dots in this one. I don't know what's wrong. So what is the role of surfactant? We are coming to the surfactant part. So this is also DNB question. This is a very important question, and if you can at least write this page, this slide which I have shown you right here, if you can write this much, I think you will get more than 50% marks for this particular question. It is a 5-mark question, so if you can write this much, I think you should get 2 to 2.53 marks easily for this question. So surfactant consists of lipids and proteins. Let me just first go through. There are two parts. First part is lipid, second part is proteins. Okay, which is more? Lipids are more. 90% is lipids. Now out of this 90%, the maximum is dipalmityl phosphatidylcholine, which is 62%. Again, this is a question which is asked by professors also, even the DNB also. Most common is dipalmityl phosphatidylcholine. Okay, then is the dipalmityl phosphatidylglycerol. Phosphatidylcholine is first, glycerol is second. How we can remember is C comes before G. C comes before G. Okay. This question was also asked in DNB post diploma CET. This is also an MCQ. Okay. DNB PDCET. This was also asked in PDCET. Okay. So maximum is dipalmityl phosphatidylcholine. Lipids are 90%. Dipalmityl phosphatidylcholine is maximum amount of lipid. Out of proteins, there are two: albumin, IgA, and apolipoprotein A, B, C, D. Okay, which is the maximum? A is the maximum. Okay, then is carbohydrates. Carbohydrates are only 2%. So what is the function of surfactant? Again, this is a DNB theory paper, and also professors can ask this kind of questions, but this is very important question in DNB theory paper. So if they have asked for the surfactant, you write this: what is the maximum in lipids and proteins, then you write the function of the surfactant, and I think this should award you 4.5 to 4 to 4.5 marks, which is good. Out of 5, 4 to 4.5 marks is good. Okay. Stability and fluid balance of pulmonary alveoli. That is the first function of the surfactant. The stability and fluid balance of the pulmonary alveoli. Surfactant may activate and exert a stimulant effect of macrophages. Surfactant activate and exert a stimulant effect of macrophages. Stability and fluid balance, right? Activate and exert stimulant effect of macrophages. Bacteriolytic effect exerted by the alveolar macrophages, right? The phospholipids of the surfactant act directly on T lymphocyte membranes to prevent excess immune response. Also prevent the excess immune response, right? And it assists the ciliary movement in upper respiratory tract, the mucociliary escalator. This is also very important question. Mucociliary escalator is also very important question. We will discuss mucociliary escalator in the upcoming sessions. Right now we are just trying to go through the basic questions and basic aspects of the lower respiratory tract. So assess ciliary movement in the upper respiratory tract, right? Stability and fluid balance, activate and exert stimulant effect on macrophages. It has a bacteriolytic effect. Also the phospholipids of the surfactant act directly on T lymphocyte membranes to prevent excess immune response and assist ciliary movement in upper respiratory tract. Okay, now coming back to the lung. Lung are the functional respiratory organs and lie on either side of the mediastinum and surrounded by pleural cavities. Each lung is a half cone shaped with base, apex, two surfaces and three borders. The base sits on the diaphragm and the apex projects above the first rib and into the root of the neck. Okay, over here we can see, right? We can very clearly see here. Can you see the apex of the lung, right? And here is the internal jugular vein. right? Okay, maybe some of you guys who have joined but who have previously worked in good institutions, they would have known how to do central line, right? You must be putting central venous catheter, CVC, right? So we put CVC in, one is in the internal jugular vein, second is in the subclavian vein, and third is in the femoral vein, right? These are the three places we can put CVC. So in subclavian vein, we all know in NEET, this is a very famous question, most common this thing, uh, adverse event during subclavian vein central line insertion is pneumothorax. Why? We can see it is right here, right above the lung. Okay, it is placed right there, right above the lung. And in, if you can see, this is the lung apex, right? And here is the internal jugular vein. So when we are putting central venous line, if you do multiple pricks, what will happen is, over here you can puncture the apex and cause pneumothorax, right? See, if you do multiple pricks, and if we cannot penetrate the internal jugular vein correctly, or we go through and through the internal jugular vein, we can also penetrate the common carotid arteries, or we can also puncture this apex, causing pneumothorax. Okay, so we have to be very careful for that also. The lung has two surfaces, the costal surface and the mediastinal surface. Why am I going on about this? Because again, this was a previous year DNB question, right? I don't. I think this is very, uh, you know, laborious for the students to remember this, but this was a previous year DNB question, so we should know and we should be able to write something about this. We are not expected to write like a textbook, like Fishman, but we are expected to write something about it. If we are asked that how many surfaces does the lung have, so lung has two surfaces, the costal surface and the mediastinal surface. We all know mediastinal surface is the inside and the costal surface is the outside. So costal surface lies immediately adjacent to the ribs and intercostal spaces of the thoracic wall. Mediastinal surface lies against the mediastinum anteriorly and the vertebral column posteriorly. Contains comma-shaped hilum through which structures enter and leave. There are three borders of the lung. The inferior border of lung is sharp, separates base from the costal surface. Anterior and posterior border separate the costal surface from the mediastinal surface. And unlike the anterior and inferior borders, which are sharp, the posterior border is smooth and rounded. Okay, we'll come to that later. The lung hilum and the root. The root of each lung is formed by pleura as a short tubular collection of structures that together attach the lung to structures in the mediastinum by extending inferiorly as a fold, which is known as the pulmonary ligament. Okay, the pulmonary ligament. So this is the root. We are talking about the root of each lung. Okay, which is formed by pleura. Okay, and it extends inferiorly as a pulmonary ligament, lies opposite to the bodies of the 5th, 6th and 7th vertebra. Okay, this is thoracic vertebra. We are talking about thoracic vertebra. The hilum of the lung is where the structures enter and leave the lung. Okay, if somebody asks, hilum of the lung is where the structures enter and leave the lung. So relations and borders of the hilum and root. Anterior is the phrenic nerve, anterior pulmonary plexus, superior vena cava, part of the right atrium near the right lung. The posteriorly is the vagus nerve, posterior pulmonary plexus, descending aorta, left lung only. Inferior is the pulmonary ligament, superior is the azygous vein and the aortic arch. Principal bronchus on one side, the eparterial and hyparterial bronchus on the other side, one pulmonary artery, two pulmonary veins. This is very important. one pulmonary artery and two pulmonary veins, superior and inferior. When we will discuss embryology, we will come to this point. Okay, bronchial arteries, one on one side and two on the other side. Again, this is very important. Bronchial arteries, bronchial veins. On one side there is only one, and there are two on the other side. Okay, principal bronchus is on one side, and epiarterial and hyparterial bronchus is on the other side. The anterior and posterior pulmonary nerve plexus, lymphatics, bronchopulmonary lymph nodes, and areolar tissue. Bilateral and symmetrical hilar enlargement can be seen in sarcoidosis. Asymmetrical hilar enlargement. Asymmetrical. If it is said asymmetrical hilar enlargement, then it is cancer. Change in position is seen in hemothorax or pneumothorax. Right? This is very important. What is the clinical importance of hilar? Okay. Here, what we can see is superior lobar bronchus, the middle lobar bronchus, right? Pulmonary artery, pulmonary veins. Correct? What we saw is there are two pulmonary veins and one pulmonary artery. Okay. So what we learned was bronchus, artery, vein on the right side. And on the left side is the Atal Bihari Vajpayee. ABV, artery, bronchus and vein, right? Okay. So right lung is divided into three parts: superior lobe, middle lobe, inferior lobe. Right? This is the horizontal fissure. Okay, and this is the oblique fissure. Superior lobe and inferior lobe and the oblique fissure. Correct? So as I told you previously also, see this apical anterior posterior. Okay, medial lateral. Okay, this is the medial, this is the lateral, and this is the anterior basal, lateral basal, posterior basal, right, and superior basal. Okay, on the left side, what we can see is apicoposterior, anterior, and posterior. Okay, apicoposterior, anterior, basal. I think this was the basal one. I'll just see and confirm it. So this is superior and this is inferior. Now what are these parts for superior and inferior? This is the lingula, right? One of my professors did ask me this question, that lingula is divided into what, and I told superior and inferior. Okay, lingula has two parts, superior and inferior. The inferior lobe is divided into superior, anteromedial, and lateral. So divisions of the bronchial tree and summary of its histologic features. In this, what is of our importance is for us It is important of the for the histologic features. Histologic features of, see, this line is very important over here. This line which I am showing you is very important. So goblet cells are seen till only segmental bronchus. Okay. Glands are seen till segmental bronchus. Hyaline cartilage is seen till segmental bronchus. The maximum amount of smooth muscles can be seen in respiratory bronchiole. This was a question which we were asked, and maximum amount of smooth muscle is seen in respiratory bronchiole. But beyond goblet cells, these are the bronchioles. See, bronchus and bronchiole, right? So this is the difference between a bronchus or bronchi and bronchiole. Bronchi and bronchiole. Bronchi and bronchiole. So in bronchiole, there is no goblet cells, right? No mucus glands and no hyaline cartilage. Okay, I think we'll finish it over here, and next time we can talk about pleura.